Good afternoon. Thank you, Andrea. Before we begin, I would like to let everyone know that this session is being recorded. These recordings will become available on our website post-session. We are very excited to have all of you join us for the 14th Dental Education Network for Texas, or DENT ECHO. My name is Kato, and I will assist in facilitating today's session. For those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions include a didactic presentation and de-identified case-based learning, and group discussion to foster deep knowledge and build individual capacity. Some notes before we get started. These sessions are enabled for closed captioning. If you would like to view captions for this session, please navigate to the bottom of your Zoom window and select the Show Captions option in the More menu. Please stay muted unless you're speaking. You can also use the chat to raise questions and share your perspective. Please remember that no personal health information is allowed in either the chat or our discussions. And to help us with attendance, please enter your name, affiliation, and email into the chat function. If you would like assistance with your connection throughout the session, please chat Andrea, our DENT ECHO IT. If you haven't already completed the pre-session questionnaire, you can do this now using the link in the chat box. To receive CDE credits, registration is required through the UT Health CDE website. We will also follow up by email with instructions for completing the post-session evaluation and attaining your credits post-session. ECHO is an all teach, all learn supported model, and ECHOs thrive on the interaction from the full learning network. So we encourage all to participate in the conversation today. We also encourage you to join by video if you can, especially during discussion portion of the session. Our session today will include a didactic and case presentation from Dr. Tavares on clinical evaluation of patients with temporomandibular disorders. And with that, we'll move on to introductions. Dr. Challa.
Thank you, Kito. Hello, I'm Suman Challa. I'm the Associate Dean for Advanced Education Programs, and great to be here. Thank you.
Thank you, Dr. Challa. And Kathleen?
Yes, good afternoon and welcome. My name is Kathleen Weeks, and I'm very excited to be part of the DENT ECHO team as the new co-director. I'm currently the project coordinator here at the School of Dentistry. Thank you for taking the time to join us today as we hear from Dr. Tavares.
And Dr. Tavares.
Hello, I'm Tiffany Tavares. I am the clinical assistant professor of oral medicine at UT Health San Antonio School of Dentistry. I want to thank the DENT ECHO team, Dr. Challa, for inviting me to give this lecture, and I hope we have a great session today. Look forward to your questions and discussions.
And one quick announcement, but ask before we move on to Dr. Tavares' presentation. During her presentation, please feel free to use the chat feature to raise any questions, but please wait until the end to have them answered. And Dr. Tavares, we're ready. If you can share your slides and take it away.
All right. Can you be able to see the slides?
Yes.
Great. Perfect. Thank you. Well, today we are going to talk about the clinical evaluation of patients with temporomandibular disorders. As mentioned before, I'm oral medicine specialist, board certified. We help manage and diagnose as part of our scope of practice orofacial pain and temporomandibular disorders. So today we will talk about the principles of pain and orofacial pain, principles of patient evaluation. We'll discuss briefly the pathophysiology of TMD, clinical examination, discuss the major diagnoses and some differential diagnoses. And the focus today is not on management, but we'll have a brief overview on the principles of managing these disorders. As we begin, we're going to talk about the principles of pain, and not surprisingly, toothache or odontalgia is the most prevalent type of pain in the orofacial region. One study conducted reported that 12 to 14% of these patients surveyed reported a history of toothache within a 6-month period. So most of our patients, if you're a general dentist, are going to be consulting you for odontologists. But not all pains are the same, not all toothaches are the same. Although most odontologia is of pulpal or periodontal origin, sometimes odontologia toothaches can be originating from non-odontogenic sources like myofascial pain, sinus disease, neurovascular disorders, neuropathic disorders, maybe entirely idiopathic, and in some rare cases can be coming from problems with the heart or other systemic diseases. So although most of them are going to be our bread and butter, pulpal disease and periodontal disease, it's good to have these other conditions in your differential when things aren't matching up. We'll talk a little bit more about that moving forward. There are other forms of facial pain in the maxillofacial region that are not odontalgia. Today, we're going to be focusing on the temporomandibular disorders. Remembering that this is very prevalent in the population, usually with young and middle-aged adults that peak around 20 to 40 years, but it's more prevalent in children and the elderly, so at the extremes. Females tend to be more affected than males with a 2-to-1 ratio. But very important to remember is that although this is very prevalent, TMDs for the most part are remitting, self-limiting, and fluctuating in intensity. The progression of temporomandibular disorders, or TMD, I'm going to say that moving forward in this lecture, is actually quite uncommon, and only a minority of patients actually need treatment. 3.6 to 7% of patients, according to some studies, actually needed treatment because we do not treat TMD in the absence of pain. And just for context, patients can have disc displacement and internal derangement of the joint, but be completely asymptomatic. 35% of those patients are asymptomatic, and we won't treat them unless there is some pain or some functional limitation. So it's important to have that context when thinking about temporomandibular disorders. So, but before we get into the weeds about all the diagnoses and that, let's think about pain. So what is pain? It is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. This is the official definition from the International Association for Society for Pain. And as we see here, most of the time we're thinking about pain, and in our scope of practice, we see something that's wrong with the patient, and the patient's complaining of pain, and those things are concordant. That's not always the case, because pain, as we see in this definition, is sensory and emotional experience. So there are many inputs that are necessary for a person to report pain, and we might not be able to actually see the lesion or the disorder observing on a clinical examination. There could be those factors that influence it, and we're going to talk about that today as well. Why do we feel pain in the first place? It instills protective behavior, right? If I burn my hand and now that's painful, I'm going to protect my hand from further tissue damage. So it is an adaptive experience. It's important for us to survive, is that we feel pain and we protect ourselves from danger. But if we have unabated pain, this can be harmful for us. And this is where we're going to talk about chronic pain as well. And that's where pain becomes more pathologic instead of merely helping us adapt and protect us from danger or prevent further damage. Important things to remember, given this context of what pain is. It is always subjective. So you can have two patients with similar observations on a clinical exam that have a completely different pain experience, because it's not due to only biological factors, it is an experience. It may or may not be tied to a stimulus that you can reproduce, And it is always a consequence of an emotional experience and psychological state. So when we're evaluating pain, we use the biopsychosocial model, and we'll talk about that a little bit more. That all these components contribute to our patient presenting with a pain complaint. Another important thing for us to consider when we are observing a patient with pain is this site of pain actually the source of the pain? So my patient is complaining of pain in a particular area. Is this actually where the pain is coming from? Or do I need to look for a different source of pain? Because although they might be seeing it here, it might be originating elsewhere. So this is very important on your clinical examination to make sure that those things are concordant or not. Because when we have a homotopic pain, or the site of the pain is the same thing as the source of the pain, let's use an odontalgia for example. Patient has tooth pain, you see a carious lesion, you take a radiograph, you can see periodontal disease or any of those actual clinical observations in the same place where the patient is complaining of pain. You can reproduce it. That is a homotopic pain. The site of pain is also the source of pain. So if you treat that site of pain, you will most likely have effective therapy. If you have a heterotopic pain, where the site of pain, patient is feeling a pain here in their tooth, but if you look at the radiograph, you look at it clinically, if you test that tooth, vitality, percussion, that is not modifying their pain experience. You can't reproduce their pain, make it better or worse. That is probably not the source of pain. We have to look elsewhere. So if I were to treat that site of pain, it's not actually going to resolve the patient's complaint because that is not the source. So we always need to make sure that we are actually finding the source. It's a very important concept in the evaluation of pain. And for the most part, most things that we treat in dentistry are going to be homotopic, but there are instances where it might not be. And that could be with tooth pain and it could also be with muscle pain. All right, so what biological factors are at play? We're going to talk about some different types of pain that are not the nociceptive, the everything matches up. These are some types of that heterotopic pain that I talked about, where your source of pain is coming from the central nervous system, but you're perceiving it in a peripheral area. So for example, brain does not have nociceptors, but you can have a brain tumor that is pressing on nerves or causing the person to feel pain at a distant site, but that's not actually where the disease is. You have projected pain, and this is when you have a pain complaint that follows the same nerve distribution as a primary source. And this will follow a dermatomal or a motor distribution. Patients might complain of hyperalgesia, meaning if you were to give them a painful stimulus, they would feel it much more painful than the amount of stimulus that you provided. An example of this would be a patient with postherpetic neuralgia. It's not a temporomandibular disorder, but this is a type of pain where the source and the site don't match necessarily, but it would have a dermatomal distribution because of where the pain is from. This is a projected pain. One that we might encounter more often in the dental sphere and talking about temporomandibular disorders is referred pain. This is when the pain occurs in a different nerve than the primary source, and it can be spontaneous, meaning it's not necessarily being provoked. And typically it's not aggravated by palpation at the site where the patient says they have pain, because the source is elsewhere. So I'm palpating the site that they have pain, or I'm evaluating that site, and I can't aggravate it. These are also not going to respond to anesthesia at the site of pain. So anesthesia can be used diagnostically when we're trying to figure out site of source of pain. I anesthetize the site of pain, and we're not getting the expected relief from the symptoms because that is not the source. These types of referred pain typically don't cross midline unless they're generated at the midline. And the referral pattern, because now this pain is coming from a distant source and being referred to this other site, it refers upwards. So from cervical to trigeminal, mandibular to maxillary, that is the referral pattern. An example of this is having referred dental pain. So maybe you have a mandibular molar that has gross caries that is being affected, but the patient is also perceiving pain on a maxillary molar that is completely intact. And this can happen in some cases because they have the same root. And this can happen temporomandibular disorders or pain in the oral-facial region that might seem like a temporomandibular disorder, but maybe you have cervical pain that's being referred to the masseter, the temporalis, referring upwards. So that's why it's important for us to evaluate multiple structures and make sure the site and the source are matching up, because we can have referred pain. And you can also have pain from the muscles of mastication, a TMD, that is referring pain elsewhere. Then we have different types of pain. We can classify pain based on their presenting features, right? How are patients complaining of the pain? So we have musculoskeletal pain that usually the quality when patients describing it to you, they'll say it's a dull, aching, pressure, tight type of pain, or they feel stiffness in the area. Occasionally there might be some sharpness, but they're more diffuse and more poorly localized and just this dull, aching type of pain. Patients can have allodynia, where normally if you were to just touch, patient wouldn't feel pain, but it's a non-painful stimulus, right? Palpation, but they might feel pain with manipulation, example of allodynia, or if you actually apply a painful stimulus that would be perceived as much more painful, that's hyperalgesia. And with musculoskeletal pain, like I just mentioned, it could be referred to or from distant sites. And typically in musculoskeletal pain, if you are using that muscle, if you're functioning with that muscle, it's going to be described as being worse with function. These are some other pains that we're not really going to talk about today, but it's helpful for us to know the different qualities and types of pain so we can distinguish them from each other. So neuropathic pain, they're going to be described as more burning, electric, shock-like. A neurovascular pain, like some headaches that can have similar symptoms to some TMD, are going to be described more as throbbing or stabbing or pounding, have a rhythm to it because we have a neurovascular component. And those patients might complain of the pain being worse when intracranial pressure is increased, like if they're bending over, if they're engaging in physical activity, or if they do the Valsalva maneuver because it's a neurovascular pain. And with certain headaches like migraines, patients can present with nausea and vomiting. That's not characteristic at all of having TMD. Then we have psychogenic pain that's very variable in presentation. It's going to be mainly descriptive, what the patient tells you, and the complaints usually don't match any kind of anatomical sensory patterns. It's just all over the place. Another important aspect when you're evaluating pain is, are we dealing with an acute pain or are we dealing with a chronic pain? Because we look at those and it's differently, and it speaks to the prognosis of the patient. So in acute pain, you have pain with close temporal relationship to a stimulus, injury, or particular disease. And the important thing is that it tends to respond to treatment in a dose-dependent fashion. So if I increase the dose of my treatment for using analgesic, I expect the patient to respond well to that, have a linear relationship, versus chronic pain, which is pain that's lasted for more than 3 months. We don't have necessarily this linear dose-dependent pain relief with our treatment. And patients with chronic pain tend to have multiple other ongoing pains. And if they do, that's a predictor that this patient is more likely to transition from acute to chronic pain. It's a risk factor. There's also a lot more influence of psychosocial factors, and these chronic pains are more difficult to treat. Like we said at the beginning, not all pains are the same. This is a figure from Dr. Erickson's book that shows you here that in acute pain, you have more biological inputs But as we go more into the chronic pain aspect, we have more input from the psychosocial factors that end in suffering and more pain type behavior. So when we're evaluating TMD, we have axis 1, which are the biological factors, and axis 2, which are psychosocial factors. Remember our biopsychosocial model. So we need to not only look at the biological factors, but the psychosocial factors when evaluating a pain patient. And that's what we're going to talk about next. And it's important for us to understand that all pain is real. Patients can become very frustrated when they present with chronic pain, in that they might have been dismissed, or people think they're exaggerating, maybe because not everything is lining up or in that dose-dependent fashion when we have, especially when we have patients with chronic pain. So acknowledging that and reassuring the patient that you believe that they're in pain is important to kind of create trust and rapport. And we need to evaluate the psychosocial factors because they can initiate pain, sustain pain, or they might develop more psychosocial comorbidities as a result of the pain that was entirely biological to begin with. The main things to look for are depression, anxiety, different types of personality disorder, how much distress the pain is causing them. Sometimes traumatic life events can be contributory or initiating factor for them developing these pain symptoms, physical, sexual, emotional abuse. We should also look at patients' coping mechanisms. This is extremely for us important for us in management. And unfortunately, some patients might be looking for secondary gains and engaging in litigation. So we need to take those factors into consideration when we're evaluating a pain patient. The coping mechanisms, some things I wanted to mention, like the major coping mechanisms are perceived control. So how much control does a patient think they have over their symptoms or their management? And this is similar to self-efficacy, but slightly different, which is, now, does this patient think they have the skills to control their symptoms? And this needs to be balanced with the perceived control, and that affects how we present a management plan. And maybe this patient needs more reassurance than others. We have the patient as a catastrophic thinker, where the worst case scenario is the default. I'm sure, as I'm saying these things, you're probably thinking of some patients that you've encountered in the past. The hypervigilant patient, this patient is alert to pain and any minor changes that might be happening. This patient's going to come to you with a binder with color-coded, date and time stamps. At 10:15, there was a rush of wind, and that I felt this symptom. And then at 12:30, this other thing happened. It's a hypervigilant patient. And sometimes we need to break down these coping mechanisms so that we can get the result that we want. And then we have a patient who's fear avoidant, who disengages from activities for fear of pain. And these lead to a lot of psychosocial comorbidities, and there are factors that need to be addressed when managing the patient and seeing what could be contributing to their pain complaint. Social aspects too, socioeconomic status, their learning. So is this a patient who responds to positive or negative reinforcement? Is this more a stoic patient who only will deal with something when it's absolutely awful, worse, and kind of there's nothing else that they can do? They've tried things on their own. They try to toughen it out. Versus an attention-seeking patient. And some patients will use substance abuse for escape. So all of these social aspects need to be considered too. Unfortunately, there's a lot of stigma and skepticism around chronic pain, which some TMD patients can present with. So breaking down that, kind of the things we talked about of reinforcing that, I believe you're in pain, let's try to figure this out together. Having support tends to be better for patients, but it's more important the type of support that they get, whether they have a support system that constantly just reaffirms what they believe, even though it may not be true, or someone's always negating what they have. And those factors can also play a very significant role in the progression or the success of your treatment. So I know we talked about a lot of things, but let's think about this scenario here where you have a new patient who has a chief complaint. My mouth is a mess. She states, no one has been able to fix this. I've seen everyone for this. I'm not sure why I even try anything because nothing ever works. I know I'm going to lose all of my teeth and I want to see if you can help me, but I don't have much hope left. Then you proceed to explain how the patient proceeded to explain how she experiences bad side effects to any medication she takes. And after finishing your intake, you ask if you can examine her, she consents. So which coping mechanism, you can put this in the chat, do we think best aligns with this patient's statements? Trying to see if I can pull up the chat. I cannot pull up the chat here. Oh, it disappeared. Yes, catastrophic. This would be your catastrophic patient coping mechanism. Thank you, Mary Jane, for your contribution to that. So it's actually important before moving on to kind of address where this is coming from, because you can have all these diagnoses and you can have all this treatment plan, but if we don't address this coping mechanism that the patient has, the likelihood that they're going to adapt and comply and all of that is reduced and your success rate will be lower. So, you know, we're treating a person, we're treating a patient, so we need to look at them from every single aspect and the things that contribute to that. Because how you treat and the considerations, even in the diagnosis of a catastrophic patient, might be different from a fear-avoidant patient, might be different from patient who had low in perceived control self-efficacy. So it's important to note these patterns. Okay, now going on to the evaluation. When you're taking the pain history, you know, we want to know what the pain characteristics are, the location, the onset, the circumstances around the onset, the quality, right? All of this is going to determine how successful, it's going to help us determine our differential diagnoses, how intense this is, what is the pattern, is it something that's happened every day, is it recurrent, is it episodic, what makes it better, what makes it worse, what comorbidities a patient may have, like we talked about the chronic pain conditions, what treatments have they had in the past, how is their sleep, does this affect their sleep, does this pain wake them up at night or make it difficult for them to even fall asleep? Is this resulting in disability where they might be missing days from work, days from school? Are there functional limitations? They've completely changed their diet because of this pain. All of these are important things for us to systematically look at when we're evaluating this patient and the different items we might need to address or consider in our contributing to our differential diagnosis. Then what kind of pain are they describing? Is this more acute, chronic? Is this actually your musculoskeletal pain? Is it neuropathic pain? Is it neurovascular? Is there a combination? Does it not really make sense? And the most important question, why are they in pain, right? So we take everything the patient's telling us and correlate that with our physical examination findings, confirming is the site and the source concordant. So this helps us determine, is this pain a syndrome or is it simply a symptom of something bigger going on? That's the difference between a primary pain and a secondary pain. Is this a referred pain? Is it central pain? Is it projected pain? All of this can help us come to the correct differential. Are there any other contributing factors? Do we see signs of inflammation? Does the patient have some systemic disease that could be contributing to this? Was there any history of trauma? Do they have parafunctional habits, psychological disorders, or social barriers in this biopsychosocial model of pain, right? We're hitting all of them here. And then once we get all of that, we're able to come up with our differentials. Now, knowing that this is what's happening, how can we modulate their pain? And this is going to determine our treatment strategies: reassurance, self-care, addressing habits, medications. Do I need to involve other providers, like maybe a psychologist, a physical therapist, counseling. We need to address their coping strategies, maybe with cognitive behavioral therapy, and in some cases, even social services when we have very, very complex patients where maybe there's a much bigger story on why they have these TMD. Now, what are the things that actually can cause TMD? Like I mentioned, we were going to ask about past trauma. So direct trauma can lead to some TMD symptoms. There's been a history of fractures. Sometimes patients can present with TMD after prolonged dental procedures, after an intubation. Yawning can lead to some of these. Indirect trauma is very controversial. There used to be thought that maybe whiplash could be associated with the development of TMD. Sometimes it can be referred cervical pain that's presenting as TMD. But there's also microtrauma. So we want to look for parafunctional habits that can lead to muscular hyperactivity. With sleep bruxism, there's some controversy around that and being directly associated with TMD, how often that is the main factor, and orthopedic instability that we're going to talk about a little bit more. For skeletal, there's origin, there's a questionable role for that. If there's a gross skeletal malformation, a very severe malocclusion, there's some data to indicate that could be within the pathophysiology of TMD. I want to talk more about this occlusal factor because this had been very controversial in the past, but research has shown consistently that there's a low contribution of having minor occlusal changes in contributing to TMD. Is it a cause versus a consequence? What we do see is orthopedic instability as being more likely to cause a TMD. And what we mean by orthopedic instability is not patients who have minor discrepancies in their bite and their occlusion, but when you've lost a lot of posterior support, because biomechanically that can change things. So missing more than 6 teeth, having a unilateral crossbite, a maxillary or a palatal unilateral crossbite, having gross overjet, right, of greater than 6 millimeters, or RCPIC slides of greater than 2 millimeters. So these are more intense, severe occlusal changes that can result from this, but it's really because it's leading to orthopedic instability. Now your muscle has to work differently to maintain the condyles in the right spot and equilibrated on both sides. And as a result of orthopedic instability, we might see internal derangements like disc displacement, osteoarthritic changes, or patients can develop myofascial pain. There are some systemic diseases that can contribute to TMD, certain endocrine infections, neoplasms. These are going to be more rare. Hypermobility, like patients with Ehlers-Danlos syndrome, or patients with altered collagen metabolism, those types of diseases can end up being more likely to develop TMD, not that they all do develop them. Looking for local factors like mechanical overload or increased intracapsular pressure. There are some studies looking at genetic factors that might cause TMD, and they've seen some changes in psychosocial phenotypic differences. That's why we shouldn't underestimate the psychosocial contributions to our patient who is presenting with TMD. So in light of all that, when we go on to our clinical examination, this is a review. All of you probably know this. We have our opening, our depressors of the mandible, we have our elevators of the mandible. When we're doing our clinical exam, we expect our patient to be between 40 to 58 millimeters, but it's also important to, when you're doing the exam and you're looking for this range of motion, to verify whether this patient can actually open all the way, or if they have any type of muscle restriction. And we describe it as a soft end feel or a hard end feel. If they can open further, where you can assist them in opening their mouth more, that's a soft end feel and indicates maybe there's more of a muscular component here versus a hard end feel where you can't open their mouth any further. That's their true maximal opening. And that might be an indication that there is some kind of internal derangement or an intracapsular issue. We want to see if the patient deviates when they're opening. If they deviate on opening and it returns to midline with maximal opening, that's a corrected deviation. It's a true deviation. And that could be a sign of disc derangement. But then you have patients who deflect, where when they open with maximal opening, it doesn't return to midline, it keeps deviating. And that's to be a sign of unilateral restricted movement. But if it's intracapsular, you will expect them to deflect to the affected side. So those are some clues of what is happening. We can do a loading test on our clinical exam where you take a tongue depressor and you put it on the posterior teeth and you ask the patient to bite down. And we want to observe if that replicates their pain and where that pain is felt. If they have ipsilateral pain, same side as where they're biting on the tongue depressor, we're loading the muscle, right? So that indicates that there's a muscular disorder component. If when they bite down, they feel pain on the opposite side, usually they will point to their joint, because now that's causing us to have a difference in the loading of both of these joints. And in an intra-articular disorder, we'll expect to have contralateral pain more in the joint when they bite down the tongue depressor. And this is just a schematic kind of showing why that's true. If you were to put something in the front, or if you put something in the front, you're kind of equalizing the pressure on those condyles. But if you put the tongue depressor on one side, you're altering the distance between the condyle and that joint space. You're making that joint space bigger on one side and increasing the pressure on the other side. So if they have pain on the contralateral side, then this is what you might expect if someone has a joint disorder and they're biting down, because you're actually altering the spaces there. We talk about imaging. So we don't really screen for TMD on panoramic imaging because it doesn't give us soft tissue, right? It only gives us gross changes. And patients who are entirely asymptomatic may have even positive or even subtle changes on imaging, and we shouldn't overestimate those. The most important thing is to have a good clinical examination and then use imaging as an adjunct as necessary, because that clinical exam is going to guide the need for more imaging. You should take imaging if it's going to inform your diagnosis or guide treatment. And you should get the correct type of imaging depending on what you want to evaluate. If it's soft tissue, panoramic's not going to do it. If it's hard tissue, there's limited things you're going to see on a pan, or you might need, if you're looking at soft tissue, you're going to want an MRI. So it depends on what you want to see. Some indications are if you have a joint pathology that's causing the pain and you're thinking of invasive treatment, if there's been a history of significant trauma that you might want to see if that's correlating with your clinical findings, acute malocclusion, and you've ruled out a dental reason for that, like a patient with an sudden anterior open bite, patient who has progressive or acute facial asymmetry. If you suspect degenerative joint disease, patient has a lot of crepitus on exam that's painful, reduced range of motion, and this patient hasn't improved at all with conservative therapies, anti-inflammatories. Patient has reduced range of motion, they don't have any pain, that's odd. And patients with sensory abnormalities, these are all some common indications to request different types of imaging. Now, trying to put some more things into context of things that we've talked about. You have a patient who reports pain on the right temporalis and on the right maxillary molars. But on your intraoral exam, the dentition is intact. You have no gross caries, no clinical attachment loss. There's no sign of tooth fracture. What are some possible explanations for her odontalgia along with her right temporalis pain? And what might you want to do next? And this is actually not that uncommon to see. where patients just have multiple pain complaints and things don't always line up. Okay. So this would actually be a scenario where we might want to investigate a referred source of pain, remembering that it refers from cervical to trigeminal upward, right? So especially a patient already has some other type of muscle pain, we would want to make sure we do a thorough exam in the cervical region, or look at the for referred pain from a different muscle to the maxillary molar. So this patient might not have tooth disease at all. We don't see caries, we don't see clinical attachment loss, no sign of tooth fracture. This is where we could do our local anesthesia to help diagnose, is there really a tooth problem, or is this coming from somewhere else? We do our vitality testing. We take a radiograph to make sure there's nothing else that can take a pan and periapicals to make sure there's nothing that we're missing intraosseous that could be explaining this patient's complaint that they don't have sinus disease, because it's sometimes we get caught up in the teeth but don't realize that there could be other sources of this that could be muscular or even other disorders underlying that. So making sure we doing that thorough examination and trying to find the source of pain. Going to our specific diagnoses when we're talking about TMD, for myalgia, this is all taken from the diagnostic criteria for TMD that's available freely online. They have an entire packet with all of this information. But it's when someone complains of pain in muscles and it's modified with jaw movement. Remember, the function we talked about is very characteristic of musculoskeletal pain. So movement, function, parafunction, patients will complain of the pain in their jaw, in their temple, in their ear, in front of their ear. It's very common for patients to come to us after they've seen an ENT because they're getting pain in that area. They look at their ear and they're like, okay, now go see your dentist because this might be TMD. And you can replicate this muscle pain, it's a familiar pain, when you do provocation testing, either with palpation or you have the patient open assisted or unassisted, and that replicates their pain. There are 3 types of myalgia that patient can have. They can have local myalgia, where it fulfills this criteria, but they only feel it under your finger, right where you palpate. Then you can have myofascial pain, which is you palpate the spot and they feel pain that's spreading throughout the entire muscle. And this is when patients might have trigger points. And then we have myofascial pain with referral, where you have the pain in that muscle, but as you palpate that muscle, they're feeling pain not only in the entire extent of the muscle, but it refers elsewhere beyond the boundary of the muscle. And trigger points can also be present here. This is when we feel a taut band of muscle. It's consistently tender to palpation, and palpation of that trigger point alters the pain, either locally or even at that place where we have referral that's distant. Patients can also report headache in their temple area, secondary to pain-related TMD. For them to have a headache attributed to TMD, that headache should be temporally related to it. And as the TMD worsens or improves, the headaches also worsen or improve. And if you have a right-sided TMD, you expect the headache to also be on the affected side, the right side. And the headache is going to be worse with movement or function or parafunction, and you should be able to have a familiar headache on palpation or opening or lateral movement. Sometimes tension headaches can be confused with headache attributed to TMD and migraines, but differently, if it being one-sided, this is going to be the cap type headache where patients just like, my entire head hurts. But it can have a mix of symptoms where there's pressure and tightness that's similar to what you have in musculoskeletal pain. And These are typically not aggravated by physical activity that you would expect in neurovascular pain, and they don't usually have nausea or vomiting, but sometimes can be confused with headaches attributed to TMD and migraines. And these tend to last longer because they're not associated with just the function. This is a schematic that's also part of that diagnostic criteria for TMD that helps you get through these muscle diagnoses. But one important differential diagnosis for muscle pain is fibromyalgia. And it's important, some of you might have had a bunch of patients that you've seen recently with fibromyalgia. It's not that uncommon of a diagnosis. And the difference here is that these patients have widespread pain, and it affects bilaterally. It's a chronic type of pain. They have many associated symptoms or disorders like mood and anxiety, irritable bowel syndrome. But 75% of these patients have their pain in the maxillofacial region and have TMD signs and symptoms. But the difference between someone who has normal TMD and someone who has fibromyalgia who's also presenting with TMD symptoms is it's going to be more widespread bilaterally, multiple muscles at the same time, cervical and the muscles of mastication. And it's diagnosed by using the widespread pain index and symptom score. But you see here, they're going to have pains in other areas as well: shoulder, arms, hip, leg, jaw, chest, abdomen, upper back, lower back. So when you have a patient with fibromyalgia and these widespread pain, you can't, but they also have TMD symptoms. We can't just think of this as a normal TMD, because if they're not getting their fibromyalgia diagnosed and or treated, your treatment is not going to be very effective. So that's an important differential. We're going to talk about our joint disorders, which are disc displacements. And this is when the disc condyle complex is dysregulated. It's a mechanical disorder. And this disc now, when you open your mouth, it reduces. And that's where we can hear sometimes that click. So you have a clicking, popping, or snapping during the jaw movement. So when you're doing your clinical exam, it's important that you have a patient open and close at least 3 times, because you might not hear it every single time. But the patient can open to normal range of motion. And on our clinical exam, we talked about the deviation and deflection. So with reduction on a clinical exam, we may see corrected deviation, that true deviation where they open, deviates, maximal opening, it goes back to midline. And we expect that deviation to be onto the affected side. Now, you can have a disc displacement with reduction, but with intermittent locking. And the difference between this one and the previous one is that the disc intermittently reduces with opening of the mouth, not every time. So a patient might report history of locking, jaw locking when they open. And they might have to do a maneuver to unlock their mandible. But the patient typically can open to the normal range of motion. Now, when we have a disc displacement without reduction, without reduction with limited opening, this is different from the other one because now the disc does not reduce on opening. And the patient has also a history of jaw locking when they're opening, but a maneuver does not unlock them. And this is a patient who's going to present with limited range of motion, so less than 40 millimeters, even when you're trying to assist them. They'll probably be modifying their diet, it becomes difficult for them to eat. And on exam, you can see more of an uncorrected deviation. So a deflection to that affected side. This one is easy because we're talking about disc displacement without reduction, but the difference here is that they don't have limited opening. So it fulfills most of the criteria of the disc displacement without reduction, but they have a maximum assisted opening of 40 millimeters. And you can also see this deviation, deflection, I should say, to the affected side. So those are like the main joint disorders that we will encounter. But we shouldn't underestimate, if a patient has generalized systemic inflammatory disease like arthritis, these autoimmune disorders can sometimes present and predispose patients to developing TMD. The difference here is that you might, with these systemic inflammatory and autoimmune disorders, see more swelling, and depending on the severity of the swelling could even lead to malocclusion, but they should have these diagnosed by rheumatologists, but they're more likely to develop degenerative joint disease. So just be on the lookout for that, because again, if we don't treat what is actually contributing to that, which might be some of their systemic arthritides, we're not going to have as successful of a treatment. We can wrap up with this case scenario and the question. So here, with all of these diagnoses that we talked about, we have a patient who's 50 years old and has dull aching pain of her left jaw. And she says that this pain has been 3 to 4 times per week for the past 7 months, but it's worsened over the past 2 months, which is why she's here seeking evaluation. And she says it's worse upon awakening and with function, like chewing or talking for a long time. Sometimes she also has headaches, and her pain is usually 2 out of 10 during the day, but 5 out of 10 when she's waking up. Past medical history, she has rheumatoid arthritis, but it's in remission. She's not taking anything for that. And she's a divorce attorney, so maybe a stressful job. And she has pain of the left masseter with spreading characteristics, pain of the left temporalis, but no spreading characteristics, non-tender click of the left TMJ when opening and closing, deviation to the left upon opening but corrects, 36 millimeters maximum range of motion with familiar pain unassisted. You can open to 41 with familiar pain. She's moderate wear facets, missing teeth 1, 4, 15, 17, 19, 31, and 32. And then 3 minutes after you finish your clinical exam, she starts reporting a familiar headache of the temporal region. So does anyone want to make any diagnostic suggestions, any additional questions, any adjunctive tests you might do to figure this case out?
Please feel free to type anything in the chat or unmute and let us know your thoughts.
Okay, we have some contributions here. So yes, she has thinking that maybe there's some nighttime grinding, loss of molars contributing factor, disc displacement, clenching. Yeah, all of these are excellent thoughts. So, so she has left masseter pain with spreading characteristics. That would be indicating some myofascial type pain, right, without the spreading characteristics, some myalgia here on the temporalis. She has a non-tender click, so there might be some disc displacement, but this isn't something where we necessarily are going to chase because it's non-tender, and this patient can actually open up to 41 millimeters with assistance. So this indicates that, most of her symptoms are muscle related rather than joint related. Yes, she has a click. There might be internal derangement, but it's asymptomatic. So that's not going to be our focus and something we're going to chase down. But the moderate wear facets, does she have some sleep bruxism? But also she's lost a lot of posterior support. So how much is one versus the other, right? But here, what indicates just that she might have the nighttime grinding, as was mentioned, excellent observation, she has worse pain on waking and with function, right? So upon waking might indicate that she's having hyperactivity during the night, if that's when her worst pain is, and loading those muscles with the clenching and the grinding. We might want to ask about the headache. because she says she gets headaches. So is this a separate headache or is this a headache associated with the TMD? So it'd be good to ask her, questions when you get these headaches. Is every time that you have the muscle pain, or does it ever happen on its own? Which side do you have the headache on? All of those would be important questions to ask. And so she might have, and she says here, so what indicates this might be more likely a TMD associated headache is that she starts feeling that headache right after your exam. And we see this all the time. Her rheumatoid arthritis is in remission, but this might, if she progresses, has more joint issues, we could have more joint issues. We could consider, whether her rheumatoid arthritis is flaring up, and the joints could be an indication of that. So we have many ways of, dissecting this and just looking at each complaint individually. What are the factors that are playing here? How can I, put all of this together? I do want to leave some time for questions. And as we wait for people who might have questions, I'll just wait as you put it in the chat, and we can, look here. This patient loses a whole bunch of posterior support, right? We have fewer pillars that are helping to distribute the occlusal forces, and that will lead to the increased activity, like what the patient is saying there, of her left side, right? Because now that masseter muscle has to be more engaged to support this. Okay, is the T-scan a useful tool? I'm sorry, a useful diagnostic tool for TMD? I am not familiar with the T-scan.
John, would you be able to unmute and let us know a little bit more about it?
I have never used that.
Yeah, can you hear okay? It's a new diagnostic tool. I still think probably needs quite a bit of research done on it, but it does look at the force that is put down on each one of the teeth around the arch. So in the future, it might be acceptable, but right now, I'm a little bit
still under investigation. So I just tried to pull it up really quickly here, and it looks like it's to assess the occlusion, right? And like we talked about initially, occlusion can have some contribution more when we're talking about this orthopedic instability, which we can note when we have, this loss of posterior support, mainly, where we would do actual, like part of this treatment plan for a patient who has orthopedic instability and lost posterior support is actually restoring that posterior support, right? Getting this patient in an RPD or something that throughout the day is going to equilibrate those forces. Yeah, but whether this T-scan is going to elucidate more information about occlusion and TMD, I guess is we will see in the future. But I have not personally used that. I don't know. I think Dr. Wright was on the meeting. I don't know if he's used it or is familiar with the T-scan.
Yeah, it's I've not used it also, but I do not recommend it either. I find other ways, better ways of identifying the occlusion rather than using the T-scan, and it's certainly not an instrument that I would be using for diagnosing TMD.
Yeah, I've not seen the literature supporting that as a tool.
Yes.
But thank you for your question, Dr. Rood. I had not heard of it because I hadn't seen it in the literature recently, but I'll look more into it now, definitely, because they're always coming out with new products, and that's why having the understanding of how everything works helps us evaluate whether this the value of these new modalities and products, what they're likely to contribute to us. So thank you for that.
Yeah, it's been heavily marketed recently, and I think
Mhm.
a little bit early to be marketing it like they have been. Thanks.
I see. Oh, thank you.
Thank you so much, Dr. Tavares. Since we're approaching 1, I would
Mhm.
like to move on to concluding the session. The slides will be shared on our website. And I just wanted to thank you so much, Dr. Tavares, again, and I wish we had more time to go over. It was such an informative presentation, and I really appreciate your didactics. And thank you so much to everyone who's joined on this session for your contribution as well. Please complete the post-session survey. And I believe Andrea has shared in the chat. And we hope to see you in 2 months for the next Dent Echo. Thank you again and have a great rest of the day.